moving swiftly on. My name's Robbie Lendrum, and I'm a Scottish expat living in London, working with these guys, and I'm very much going to follow on from Zane and try and drill into perhaps some of the reasons why these patients die so quickly from a pathophysiological perspective, to then try and understand how we identify these patients, but also develop physiological targets to try and prevent or avoid exsanguination and traumatic cardiac arrest. But Zaid has already made this point. Trauma is a disease of time. We can treat some of these conditions in the pre-hospital phase of care, like attention pneumothorax, we can treat that. But the majority of the patients we're focusing on, so patients with major injury, hemorrhage, who rapidly die, ultimately need surgery or intervention to control bleeding. And that pre-hospital time is very closely linked to outcome. So that has to be the forefront of everything we do, especially if you're going to try and develop complex intervention to deal with these problems, which take time. You need to be very mindful of this. If you look at our data set, Zane's data, code red patients, so bleeding patients who are getting a blood transfusion, the number needed to treat, if we can keep the pre-hospital time from injury to arrival in hospital less than an hour, the number needed to treat to save a life is 5. That is profound. It's such a massive impact on patient outcome. So we have to be, extremely careful if we're going to look at complex intervention to try and save the proportion of patients that Zane was talking about before. But if we just focus on getting these patients to hospital more quickly, and I just want to put this graph up again, because it's so important, we miss the elephant in the room, the massive opportunity, which is that if we're really going to affect outcome after major injury, preventable death from bleeding, we have to focus our efforts in that first 30 minutes, which is the ethos of this conference. But that's where it is. And unless you look at that population level data, if we focus our energies down at the in-hospital phase, we're missing the point. But this doesn't come without challenges. Many of you may look at that and say, well, half an hour, we don't even get to a patient within half an hour. And that might be the sad truth. Perhaps these patients are destined to die. But the reality is, if we want to change this, that's where we have to focus. And in London, I guess we are lucky because we can realistically hope to try and intervene in that timescale. But what I want to do is understand why they're dying so quickly, because that's how we move forward in terms of intervention. So I actually put this up 2 years ago, this slide, but it's fundamental to, I think, how I understand it. And from Sammy's introduction, I got the impression he doesn't believe me or he's suspicious. So I'm going to keep going on about this. So this graph summarizes more than 150 years of physiological research. The black line is your measured aortic pressure, which you'd seen an arterial line trace, I'm sure you're all familiar with. But the blue and the purple lines represent antegrade and retrograde pressure waves, which are involved in the propagation of systolic blood pressure. But the red line is the reservoir component. And what Otto Frank originally described that as in the 19th century, essentially you eject blood through your aortic valve against resistance, you generate pressure, but it stretches your thoracic aorta. In diastole, with the aortic valve closed, that potential energy is released with recoil, which generates diastolic blood pressure, which, as you can see in the graph, that reservoir component is almost completely responsible for generating diastolic blood pressure, okay? And that's important because I'm going to try and do this pointer thing. This is your diastolic blood pressure. And the gradient between this and your left ventricular diastolic blood pressure, or your transmural pressure, is a pressure gradient that ensures coronary perfusion, which almost exclusively, 75% at least, happens during diastole. Okay, so this function is super important for myocardial perfusion. Okay, without it, it's likely you'll develop myocardial ischemia. The problem is, if you have a hole in your arterial system, so not necessarily a hole in your aorta, but anywhere in your arterial system, probably down to the level of third order artery, so your superficial femoral artery, for example, if you have a hole in that system and you eject blood, the effective resistance you are ejecting against is less, so you generate less pressure, less thoracic aortic stretch, less storage of potential energy, and that recoil happens against the system with a hole in it. So I think it's likely that you lose your physiological mechanism for generating diastolic blood pressure if you have a hole in the system. And I think Zane's analogy, I think he described to me, is it's like trying to blow a balloon up. It's got a pinhole in it. Okay? You can't do it. On top of that, there's another problem. So this graph is from a guy called Johnny Morrison's work. He works at the Mayo Clinic in the States now. But essentially, this is a large animal model of hypovolemic shock. So these are pigs who are venesected until they're hypotensive, so pure preload reduction. They don't have uncontrolled arterial bleeding. And they've got a flow probe on the left main coronary artery. So they're directly measuring coronary blood flow. And on the top is normal diastolic blood flow. So the uptick is essentially ventricular relaxation, coronary perfusion. But on the bottom, so these are pigs with a systolic blood pressure of 50, the uptick above the blue line is flow during diastole, but you can see that you actually start to get retrograde flow in your coronary arteries during systole, which is essentially due to the difference between the low aortic root pressure and you've still got a ventricle that's contracting. So if you imagine your trauma patient who has a structurally normal heart, who has a hole in the artery somewhere in their body, not necessarily the aorta, who's losing volume, losing preload, but also has a hole in the arterial system, it's likely that they develop retrograde flow during systole and lose the ability to generate diastolic blood pressure and then perfuse the heart during diastole. So it's likely that you can induce pretty profound myocardial ischemia in this context, which I think is one of the reasons why we see this rapid death. Okay, so I think we need to move beyond just the blood pouring out. We need to pour it in. We need to think about why these patients' hearts are stopping, and I think this is the mechanism for that. And obviously, we have to validate it to convince Sammy, but there's still work to do. But I think that's the pathophysiological process that leads to this rapid death, as Zane's already shown us. But we also know from our data set that the patients that do survive the hospital with injury then die in the ICU in the London trauma system. The vast majority, more than 80%, die with severe cardiovascular dysfunction. So they don't die of renal failure or respiratory failure, they die of cardiac failure. And that's the end point to this process for even the patients that survive the hospital. So what are we going to do about it? Well, in terms of physiological targets, I think there's some really interesting data out there in various data sets, but this is from another air ambulance organization in the UK, EAAA, and this is a guy called Paul Rees, who's a colleague of ours. He's an interventional cardiologist and a pre-hospital care doctor. And this is from their SPEAR data set. So they're putting in arterial lines into patients with medical cardiac arrest, so not trauma patients. And then these aren't having REBOA or anything like that, just external cardiac massage, adrenaline. And what they found in that data set is that essentially the maximum diastolic blood pressure is far higher in the patients that get ROSC. But interestingly, if you don't have a diastolic blood pressure above 28 millimeters of mercury, none of these patients get a return of spontaneous circulation. And actually, for every 1 millimeter of mercury increase in the maximum diastolic blood pressure, there's a 5% increase in the chance of ROSC. And that's because coronary perfusion pressure is directly proportional to your aortic diastolic blood pressure, okay? So in terms of physiological targets in our trauma cohort, it's likely that we need to increase diastolic blood pressure to ensure coronary perfusion to either rescue or prevent traumatic cardiac arrest. And then we come on to the intervention. So in my opinion, the modest aortic balloon occlusion catheter is probably the best way that we have to achieve this, and with any degree of finesse. But when you utter the letters R, E, B, O, and A, you generally one of two things happen. We have some of us are like, yes, this is the answer. It makes sense. We can do it. And then everyone else is like, this is the devil. We shouldn't be doing this. But I want you to think about it from the patient's perspective, from a physiological perspective, because I think there is potential to rescue some of the patients Zane was talking about with this. But I think we have to first discuss one of the reasons why there is a bit of a bad vibe about this. And I was involved in implementing this trial and leading it in the UK. Sammy and I sort of set it up. And Jan Janssen, who's now in the States, was the chief investigator for this trial, which was published over a year ago now. And I think John did mention it in last year's meeting, but I think it's important we just dwell on that before we go on to present just some data from our own service before I finish. But this was a randomized trial, Bayesian trial, standard major trauma center care in the UK compared with standard major trauma center care plus the intervention of REBOA. It's a Bayesian trial, sample size of 120, that was the target. A Bayesian trial gives you probability of a specific treatment effect given the available data rather than a frequentist approach. Smaller sample size, but it was stopped after 90 patients. And of the 46 that were randomized to REBOA, less than half of that group actually received the intervention of REBOA. But nevertheless, the mortality was higher in the interventional arm, 54%, v 46%. And in the intention to treat analysis, the odds ratio that REBOA was harmful was 1.58, an odds ratio greater than 1 significant in terms of REBOA being harmful. And that was with a high posterior probability in this Bayesian study. So that wasn't the result we were hoping for. But when you think about time, it's not really unexpected. And there's a really important lesson in this. So the main difference between the two groups was that there was a 20-minute delay to definitive treatment in the interventional arm, presumably as a result of attempts at REBOA. There were some other differences as well, but that translates into a relative risk increase of death in 90 days of 30%, or a number needed to harm of 8. But if you think about that in a temporal context, so this is another data set which has been illustrated by John Holcomb to make the point. Essentially, as Zane highlighted earlier, peak death rate within minutes of injury, an exponential decline after that. And this has been marked with a green or a blue, an orange and a red line to try and, illustrate the potential for improved outcomes. As in, if you can temporize that bleeding in the pre-hospital phase of care, you've got a much better chance of improving outcomes than if you leave it to the operating theatre, which is the red line. But what actually happened in UK REBOA was the REBOA intervention was delivered a median time of 2 hours post-injury. So actually the intervention was delivered when, Holcomb was, suggesting these patients should be in the operating theatre. So if you imagine a small delay to definitive treatment at this time point, it's not surprising that there was a slight increase in mortality. So this is not really what we set out to achieve, but there's a very important lesson in there. And I think this is my take home from this trial, that, we missed the window of opportunity by the nature of the system in the UK. But we still think there is potential with this type of approach to try and rescue the patients that Zane highlighted earlier. So this, just to finish, is some new data, which was, it was published last year, relating to feasibility of this intervention and the hemodynamic performance of it in our patient cohort. Okay, so we asked ourselves this question. These are the objectives of this trial. Was it feasible to deploy this intervention in exsanguinating trauma patients, and what was the hemodynamic response? Whether it was feasible to deliver partial REBOA, and assess technical performance, then look at clinical outcomes and safety. So essentially the intervention is, is basically deploying a thoracic aortic balloon. You inflate the balloon, try and rescue the situation, and then allow some flow past the balloon to mitigate the distal ischemia that you create. So avoid traumatic cardiac arrest, then mitigate distal ischemia. And we're measuring pressure from the tip of the catheter and from the side arm of the access sheath. So arterial pressure is above and below the balloon. This was an observational study, an ideal 2A study, and patients were followed up to death discharge on 90 days. We tried to include adult trauma patients who the team felt were imminently going to have a traumatic cardiac arrest or had recently had a traumatic cardiac arrest and were amenable to treatment with this intervention. And the primary endpoint was really the proportion of patients that we were able to deliver this. But I think it's important to understand the partial REBOA component. So essentially, we're trying to allow some flow past the balloon. When you occlude the aorta with a REBOA balloon, the distal arterial pressure is never zero. It's always about 10 to 15 millimeters of mercury due to retrograde venous pressure and other things. So we're looking for an increase of 5 to 10 millimeters of mercury above the baseline pressure post-occlusion. And that's about 250 to 500 mils per minute of flow in an animal model. So that's what we were targeting. Also looking for return of pulsatility, like as an arterial blood flow below the balloon, or the arterial blood flow was not lost at any stage, so straight to partial REBOA effectively. So the 21 months, the service saw nearly 3,000 patients during that period, and we tried to do this in 16 patients. So still an infrequently deployed intervention. We also do this in the distal aorta for pelvic fractures. So this is only the patients who had more proximal aortic occlusion, targeting patients who we thought had abdominal bleeding or were in traumatic cardiac arrest. So profound shock. Predominantly a young male cohort, on scene about 21 minutes after injury, same as the data Zane showed you earlier. So pretty rapid response. But these were profoundly injured patients. So a median injury severity score of 50, and a median blood pressure of 58/35, with 3 patients already in traumatic cardiac arrest. So this is the whole cohort, and I put it up just to try and describe what happened. So if you start at the bottom, cases 15 and 16 had a sheath put in. Then the team decided not to perform REBOA because they'd responded to resuscitation. Okay, so forget about them. 12, 13, and 14 were failed attempts at femoral access. So the team tried to get femoral arterial access, failed. All of those patients had a resuscitative thoracotomy for aortic control, and they all died. The remaining 11 patients had REBOA. And you can see the spectrum of injuries. Actually, interestingly, there's only 3 patients with penetrating injuries in that cohort. And there's a number of reasons for that, which I'm happy to discuss later, but which are interesting. But these are big mechanisms of injury. You've got a guy who fell 48 meters into a basement. Huge mechanisms of injury. Crushed, falls from height, hit by trains, stabbings. So big injuries. This is the REBOA cohort in isolation. By the time the intervention happened, 46% were in traumatic cardiac arrest clinically, so unconscious with no palpable pulse, with a median measured blood pressure in the cohort of 47/28. In terms of hemodynamic performance, on the left of the graph, the initial hemodynamic physiology that was measured on the arterial line. After REBOA, there is an improvement, but it's actually quite modest. We don't have any patients with hypertension, still quite hypotensive cohort. So gradual recovery. Partial REBOA was instigated, and actually patients maintained hemodynamic stability after that point, which was sustained to the emergency department. So in terms of median improvements, 52 millimeters of mercury improvement in the systolic blood pressure and 42 millimeters of mercury in the diastolic blood pressure. But this is, I think, key. So the median diastolic blood pressure prior to intervention was 28, which is interestingly exactly the same as in that medical cardiac arrest cohort where you had no ROSC with a blood pressure less than 28. And we were able to increase that significantly to a point where you've gone from, a situation where imminent traumatic cardiac arrest is likely to a situation where you're probably going to perfuse the heart. And this is just a clinical example of that. So on the left, wide pulse pressure deteriorating, immediate jump in the diastolic blood pressure with REBOA intervention. So it's likely we're able to restore myocardial perfusion to a degree with this intervention in this context. And that's essentially what a case looks like. So the blue shaded area is the pre-intervention blood pressure, systolic diastolic blood pressure with a mean. There's actually a sheath upsize from a small arterial line to an 8 French sheath. The intervention happens. You can see at that point, the patient is, has a diastolic blood pressure of less than 20. There is then this gradual slow increase over about 10 to 15 minutes in blood pressure, which I think is cardiac recovery, as well as a degree of preload restoration. And then once the proximal hemodynamics have improved, we have this shaded area is the distal sheath pressure. So the increase in the distal pressure, partial REBOA, with a bit of a dip in the proximal hemodynamics, but sustained to the emergency department. So I think we are able to rescue the hemodynamics for these patients with this interventions, but there are lots of complexities. This is the visual abstract from the trial, just to summarize it. So we went from a position of 46% of patients in traumatic cardiac arrest to none of them being in traumatic cardiac arrest on arrival at hospital. One patient died on scene. We were able to deliver partial REBOA in 73% of the patients. The 3 patients where it was impossible had ongoing proximal hypotension, so they never really recovered. There was not a situation where it was feasible to allow partial flow because the proximal hemodynamics never really recovered. And we were able to rescue the situation and get these patients to hospital alive. Their 24-hour survival was 73%, but survival to hospital discharge was only 18%. It's 25% in the partial REBOA cohort. So although we're able to get these patients to hospital, there still is a significant incidence of late death. So this is very much the start of this journey, I think. Obviously, this takes time, and time is fundamental to this patient group. And really what I think we now need to do, that we can do this, but we now need to deliver it in a package that is far faster. These patients, apart from one, all had the intervention on scene. I think I envisage as we move forward, especially with penetrating trauma, this intervention happens while moving to hospital. So arterial access on scene, then this happens en route to really bring down scene time. And that's what Sammy's going to go on and talk about, this concept of damage control pre-hospital care. So really cutting corners, really trying to do things en route, pushing away interventions that we might have prioritized in the past and purely focusing on the physiological endpoints that are associated with, rescuing the situation. But that comes with its challenges. And I'll leave, Sammy's going to come on and talk to us about that. I think I'm going to stop there. Yeah. Thank you. We'll look forward to talking more about it in the bar later.